Good evening. Welcome to the SSIM NCD Expert Committee Webinar 2025. So today we are going to listen to a very important topic for all doctors, the role of new generation insulins in the management of diabetes. I'm Chamila Mettanand. I'm the chair of the NCD Expert Committee. I warmly welcome Dr. Madhuvanti Hettiarachchi, the president-elect of SLSIM, Dr. Pankaj Shah, our speaker today, and all the participants who have joined online. So to start the proceedings, I would like to invite Dr. Madhuvanti Hettiarachchi to address the gathering. Over to you, Dr. Madhuvanti.
Thank you very much, Shamila. Good evening, ladies and gentlemen. As the President-elect of the Sri Lanka College of Internal Medicine, I would like to warmly welcome you all to the first expert committee webinar, NCD Expert Committee webinar. And as you all are aware, the college has actually got four expert committees, NCD, Toxicology, Human Care, and Research. Each committee will be hosting a webinar monthly to share the knowledge among members with the help of a renowned speaker. Today we have got Dr. Pankaj Shah, Professor of Medicine, Assistant Professor of Medicine, Consultant Endocrinologist and Internist, all the way from Mayo Clinic, Rochester, Minnesota, USA. And he's not a stranger to us. We have met him during our last SIM concessions as a pre-congress. He was one of the panelists. And today he'll be speaking to us with regard to the role of new generation insulin in the management of diabetes. We are ever so grateful to Dr. Pankaj Shah for accepting our invitation amidst his busy schedule, as well as the time difference. I know it's morning there. And I should also thank Professor Chamila Mettananda, who is the chair of the expert committee of NCD, for rekindling the links with the Mayo Clinic and coordinating today's webinar. Without further ado, let me invite Chamila to introduce our speaker formally and to start the webinar. Over to Shamila. Thank you.
Thank you, madam. So before introducing the speaker, I thought I will give some housekeeping messages. So first of all, we would like everybody to mute your speakers. And then we will take up questions at the end of the talk. You can type in your questions in the Q&A box, and we will take them up at the end. And we will be offering CPD points for this lecture, as well as we will deliver an e-certificate for this. So if you want the e-certificate, you will have to fill a Google form. So at the end of the talk, we will show a QR code and a link. You can register on that so that you will receive your e-certificate within next 2 weeks. So without further ado, I'm going to now introduce our speaker today. So our speaker is Dr. Pankaj Shah. He's the chair of Hospital Endocrinology, Diabetes and Transplant Endocrinology at Mayo Clinic, Rochester, Minnesota, USA. You may be aware that Mayo Clinic Rochester has been ranked as the #1 hospital in the world for endocrinology in 2024 by Newsweek. So this is the best. We are very grateful for Dr. Shah giving us time and talking to us, enlightening our membership on an important area in diabetes. So Dr. Shah was graduated MBBS and MD at University of Delhi, India, and he obtained his DM at All India Institute of Medical Sciences. He worked at AIIMS for 11 years before leaving for US. And then he had been on staff at Mayo Clinic since 2007, for a long time now. He has several national, international publications, and he's a reviewer for most of the prominent endocrinology and diabetes journals. His main interests are management of non-diabetic hypoglycemia, diabetes and other endocrine problems in patients with complex clinical conditions, endocrine problems in patients undergoing transplantation. On a personal note, I was fortunate to have a short fellowship under him as a global physician scholar of the American College of Physicians this year, um, this April, uh, at Mayo Clinic. So thank you very much, Dr. Shah, for accepting our invitation despite your busy schedule. So without further ado, I hand over to you for your to enlighten us on this important topic. Thank you, Dr. Shah.
Thank you, much. I'm delighted to see you, at least on video here, and see my other friends here. So I will be talking about the role of new generation insulins, not the other injectables. I'm sorry, I did not edit this note enough. So this is the only slide in physiology, I think, that we will discuss. So this is the data published from Mayo Clinic in 1980. And on the upper graph are the glucose concentration, and lower graph are plasma insulin concentrations as measured in a person without diabetes. And as you can see, the glucose concentration increase after breakfast, noon meal, evening meal, and bedtime snack, and then they are stable thereafter. And that's because we always have some insulin around, and then we release insulin with each of the meals. So this is the averages. So if I remove the whole range, but just keep the averages here, what happens in people with diabetes, of course, the blood sugars are high. And to treat that, we give a long-acting insulin either in the morning or at bedtime or twice a day, whatever. And then we give rapid-acting insulin before each of the meals and before the snack as well. That gives us some insulin concentrations much better than what they are otherwise. And that gives us glucose concentration somewhat similar to what one would see in people without diabetes. So this is real data from real patients at Mayo Clinic once upon a time. But what reality is also is that when we use this plan, there are areas where glucose concentrations are high, early morning hours, after meals, and early morning hours is starting in the mornings. It's not from midnight to midnight, but from starting 7:30 to 7:30 a.m. next day. Also, what is notable, there are several times the glucose concentration is below the target range. So that is the problem of using multiple daily insulin injection plan. The problem is that the bolus insulin does not act quickly enough and glucose concentration goes high. It does not decrease quickly enough, so glucose concentrations are lower later on, and it is not senior, but has a lot of variability from day to day. And basal insulin may not last long enough. By next morning, it is weaning off and the glucose concentration is going above target even before eating. And that may be excessive at the middle of night when the glucose is low, and then that may be inadequate at other time points in the morning as we saw. And then there is a lot of variability of basal insulin as well. In addition, as you can see here, and sometimes we have to give long-acting insulin twice a day, and sometimes the dose is more than what a pen would deliver or a syringe would deliver. So there's a problem of too many injections these patients have to deal with. So these are the problems in reality when we use insulin. So let's talk briefly about insulin. On the left panel here is the diagram from way back when in 2003. This is actually um, uh, Hodgkin's data, getting her first name, but so she got a Nobel Prize for describing the structure of the protein molecules. So in insulin, she described this, that insulin subunits A and B join together to form monomers. They join together to form dimers. The graph from the top, the image from the top, and three dimers form a hexamer, beautiful graph, the beautiful figure that you see on the top on the left. So these hexamers have to be broken down to dimers, have to be broken down to monomers before they can get into blood. And that is why the insulin does not act immediately after injection, because it forms these hexamers. And these hexamers are around a small molecule in the middle the zinc ion in the middle, not a molecule, a zinc ion in the middle that keeps the hexamer in place. So that is the on the right side is the two chains of insulin, and these can be modified some or the other. We can modify uh, the 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 um, the the B chain to get insulin in a form that will not form hexamers as tightly like what is done in Lispro or Aspart or glycine insulin, and they're absorbed quicker. Or we can change to extend the life of this insulin, like what Novo Nordisk has done with Glargine and then marketed by Sanofi. But and then they have Novo Nordisk has come up with the insulin which attaches itself to free fatty acids, forming detamere insulin, or even longer free fatty acids causing degludec, and we'll see some more insulin around. So, what preparations do we have for prandial insulin, for male insulin, regular insulin, and rapid acting insulin? And without going in too many details, but rapid acting insulin compared to regular insulin, compared to human insulin, the rapid acting insulin acts quicker and goes away quicker. There is small difference between the two. The bottom line, the rapid acting insulin are the data of this data that I'm showing is from Lispro, but data from Aspart and glulicine are very similar. So in a meta-analysis on rapid-acting insulin compared to regular human insulin, there are 9 trials. None of them are blinded. They are short duration trials, as you can see there, of about 2,700 people. And there is a small difference in hemoglobin A1C by about 0.15 percentage point, but not more, and better with analogs than with regular insulin. And mind you, they're not blinded, so you can take it with a pinch of salt. There is no difference in severe hypoglycemia and overall hypoglycemia. Also, there is no difference. There are 2 trials reporting that nocturnal hypoglycemia is less with analog insulin. Once again, not blinded, so it's a good question one should keep in mind. Otherwise, there is no difference between the two, no major difference in quality of life. If you believe 0.15 percentage point hemoglobin A1C is different, then I suppose rapid acting insulin is better than regular insulin. In any case, regular insulin is barely available now, and we all use rapid acting insulin. There is no difference in weight gain while using these agents. And of course, there is no data to find out if using rapid acting insulin will have less complications, diabetic kidney disease, eye disease, foot disease, etc. So we don't know which way the rapid acting insulin is better than regular insulin. The question then comes up, even with rapid acting insulin, we get that postprandial hyperglycemia followed by hypoglycemia. Can we make it work faster? Well, what we can make it work faster by using what is called inhaled insulin. It's a stable powder that can be inhaled. It's rapidly absorbed under the neutral pH in the lungs. And this is the insulin concentrations after using inhaled insulin versus using rapid insulin Lispro, as can be seen. So there's very rapid onset and very rapid offset with inhaled insulin. And the meta-analysis would show, well, before that, this insulin is going to be available. I understand Mankind Pharma is reaching Sri Lanka. So the meta-analysis saw 13 trials for qualitative and 12 for quantitative meta-analyses, and that hemoglobin A1C declines less than what happens with subcutaneous insulin. There is less weight gain with subcutaneous insulin. There is less weight gain with inhaled insulin. There is less risk of severe hypoglycemia with inhaled insulin, and there is more cough with inhaled insulin. And the bigger problem is there is more significant decline in FEV1 with inhaled insulin. There is no difference in quality of life and overall patient satisfaction. So my biggest 2 concerns are cough and decrease in FEV1 for the duration of the study. Of course, what will happen if we use these insulin for 20 years? Who knows? And that's the problem with inhaled insulin. As more data emerges, more data as accumulates, we will be little wiser about inhaled insulin. I understand inhaled insulin prescriptions are increasing in the United States. The other option is to use a ultra-fast acting insulin, ultra-fast Aspart or ultra-fast Lispro. The light gray here are the trade names. They may be slightly different in in Sri Lanka, then there are other places. So what is done here is there are some additives that increase blood flow, increase capillary permeability. So blood is absorbed quicker. In FES, there are three excipients. Vitamin B3 is added. It locally enhances the rate of absorption. Arginine is added to increase stability, and zinc is added to stabilize the insulin hexamers. So this is the difference between SPART and ultra fast SPART. The black one is ultra fast SPART, as you can see. The ultra fast SPART acts quicker and goes off quicker. Very subtle differences, though they are statistically significant, but there are subtle differences between the two. So if the ultra fast insulin is given before meal and the fast insulin aspart is given before meal, ultra fast insulin at the same dose brings down postprandial glucose by about 10 to 20 milligram per deciliter, as can be seen here. But the trick would be if we can use so if we give mealtime insulin aspart but give post meal ultra fast insulin, then the glucose concentration is similar. So you can imagine that ultra fast insulin can be given post meal and achieve similar glucose concentrations. So the other ultra fast insulin is, of course, Lispro ultra fast, which is called Lispro AABC, which does not stand for anything. The trade name is given here. And they add two things in it. Trepoprostenol promotes vasodilation, and citrate increases permeability. And this is the concentrations if both of them given at mealtime. The mealtime ultra fast Lispro has lower glucose concentrations compared to mealtime Lispro insulin. And if we give the ultra fast insulin after eating, this is what happens to glucose concentration. They are comparable to mealtime Lispro insulin. So both these imply that we can give ultra fast insulin after eating and still achieve similar glucose concentrations. If we use it along with the mealtime, then there'll be lower glucose insulin concentrations in the postprandial phase. So they have been used in insulin pump. There is increased time in range if somebody is using pumps here, but there is increased risk of infusion blockage, tubing blockage, and need to change the infusion sets more often. So there are some issues, at least with some pumps, we don't use some of these ultra-fast insulins. There are comparable reduction in hemoglobin A1C and comparable rates of hypoglycemia and BSA10. So this is where we can increase the duration, the onset of action, and reduce the duration of action. So inhaled insulin acts too fast, very short acting, but the problem is FEV1 reduction. And ultra fast insulin, aspart and Lispro, it may be useful for after injecting after eating, because some of us like me are not sure how much they're going to eat when they start eating, and they may not know how many grams of carbohydrates they are eating, etc. So they may be helpful in some people with type 1 diabetes. So other issue then is that basal insulin may not last long enough, as you can see at about 7:30 a.m. by the green shade right in the beginning. I don't know whether you can see my cursor or not, but let me see if I can. That's a cursor, is it? Laser pointer, yeah. So as you can see here, there is insulin concentrations are decreasing early morning hours, otherwise called dawn phenomenon. It may be dawn phenomenon, it may be because the long-acting insulin is not lasting till next morning, and the glucose concentrations may go higher. So then what can be done is we can have even longer acting insulin preparation. One of them is U300 insulin glargine, otherwise called 2JO. And the theory is that if there is larger surface area for absorption, the insulin is absorbed faster. But if we make it more concentrated, the surface area for absorption is smaller, so insulin will be absorbed slower. And there is some data which implies that using 300 insulin, the slope is less and it lasts longer while taking U300 compared to U100 insulin. So however, it is slightly less potent. It doesn't matter. You can increase the units of insulin taken, but there are no major safety concerns. And there is some data which suggests that there is lower weight gain with U300 compared to U100 insulin. And hemoglobin A1C reductions are similar, with possibly lower rates of hypoglycemia. This is to summarize then in type 2 diabetes, comparable classic improvement. In type 1 diabetes, also comparable classic improvements, possibly less frequent hypoglycemic events in type 1 diabetes. The other insulin we can use is insulin Tresiba, which is this is the standard A and B chain of insulin, in which what they have done is they have modified this particular amino acid here, change it with threonine, and added a free fatty acid moiety to it, so it becomes longer acting, and it forms long chains in the subcutaneous space, and then gradually it is released in subcutaneous space, and the half-life becomes 25 hours compared to half-life of glargine, which is about 16 to 18 hours or so. So this is where it is at various levels of insulin degludec. The insulin concentrations are pretty steady throughout 24 hours. So what about the outcomes with degludec in type 1 diabetes? A comparable reduction in hemoglobin A1C, and it seems there are lower or same overall nocturnal severe hypoglycemia, and type 2 diabetes have a similar data when compared to glargine U100 insulin. The variability is less, and I'll come back to that in a moment. Then there is another insulin called icodec insulin, which has not been approved to be used yet. The half-life is 196 hours, and what they have done is to increase the size of fatty acid chain some more. And this data published just about a year and a half back, showing that they may have slightly better control than glargine, more area under curve, as can be seen in icodec compared to glargine, week 48 to 52 or 74 to 82, and the better control of hemoglobin A1C, more people achieving hemoglobin A1C in target with icodec compared to glargine U100. There is some differences in hypoglycemia with these agents, but these are not statistically significant. And as regards severe hypoglycemia, if anything, it appears that 9.8 versus 10.6 in glargine, or 12.4 versus 14.2 in glargine, that there is no increase, there is no signal of increase of severe hypoglycemia or combined significant hypoglycemia. Then there is another long-acting insulin just published a few weeks back. This insulin attaches itself to the FC component of our immunoglobulin, and that increases the half-life to 17 days, actually. And this is the recent publication in New England Journal of Medicine showing that compared to glargine U100, there is similar sort of hemoglobin A1C concentrations and similar fasting glucose concentrations, and then better achievement of hemoglobin A1C below 7% or below 7%, excluding hypoglycemia. And overall, there is no difference in rates of hypoglycemia, either clinically significant hypoglycemia or severe hypoglycemia. If anything, clinically significant hypoglycemia appeared to be slightly less in those using this long-acting insulin as FC Tora, if you may. So the problem, again, this has not been approved yet. So we'll see when it's approved, and we'll see what the experience is. Then the next question is that there are too many injections and there is pain in injection every time. So what we can do if there is painful, there is some data that implies that if it moves, that the volume of injection or the speed of injection does not matter as long as the volume is 0.1 unit, 0.4 or 0.8, 0.1 ml, 0.4 or 0.8 ml. But once it goes beyond 2 ml, the pain is more. The speed of injection does not really matter as one would look at this data. So it's not the speed, but the total volume of injection that determines the pain of injection. So what can we do if it is painful? We can use higher concentration of insulin, so volume will be less. Or of course, we can use inhaled insulin, then there will be less pain. Mind you that pain from insulin glargine is more than others because glargine is much more acidic than other insulins, and then acidic injection under the skin is more. Also, the pain is more when the needle is reused. The pain is more when the insulin is taken cold rather than at room temperature. What about the maximum dose per injections? Can we think about reducing number of injections and thereby reducing number of pens? These are various pens available in US. I just have summarized here. And as you can see, either they are 30 units maximum or 60 units maximum with one injection, or 80 units with maximum one injection. These are the other pens that are use cartridges. But then there are some pens which use more concentrated insulin, and these are the ones that can give up to 160 or up to 300 units of insulin in Humulin R U500 pens. So one can use one of these concentrated insulin if the dose is more and we have to take 2 injections to get 120 units, for example. So sometimes there are more than one injection is required because it's more than so many units of insulin per injection can be given, per pen injection can be given. So we can use concentrated insulin. And the next question, of course, is basal insulin is not lasting long enough. We can use the a longer acting insulin 2JO. We can use Degludec, and we can use uh, for that. And the next issue is about day-to-day variability of insulin. And that is the next problem that we will discuss, that basal insulin has a lot of day-to-day variability. I'm not talking of bolus insulin because we don't have any easy solutions for that. So this is the coefficient of variation of insulin glargine, and there is substantial high bar graph above the baseline or below the baseline, as one would expect, depending on the duration after injection, as can be seen here. So compared to U100 glargine, if you use if you use U300 glargine, that variability is less compared to 82% of CV. It becomes 67% of CV, but 67% of CV is also very high. So compared to these glargine preparations, if we use insulin degludec, there is much less variability, maybe 20-30% or so, which is also obnoxiously high. So this is what we face. We use insulin, same dose, and next morning we check glucose. It is different. Is it that patients took a snack at night? Is it because insulin was not working long enough? Is it because the variability of action of insulin, etc.? That's very, very frustrating, but there can be some differences in different insulin preparations in terms of day-to-day variability. So if we are worried about day-to-day variability, this we can use insulin degludec or even insulin glargine has slightly less variability than insulin glargine 100. So we can go to U300, which is 2JO. I'm sorry, I did not mention the brand name here. This is not that important in people with diabetes type 2 who are making some insulin, but becomes critical in those who are making no insulin, or classical type 1 diabetes, very small doses of long-acting insulin. Then it becomes very critical in using more stable insulin like Degludec or Icodec or Efsitora whenever those come out. I think it'll become more important in those individuals. Then the last thing to discuss about is that sometimes the situations is like that my grandma is that she now cannot take her insulin herself. Sorry, before that, that she does not remember taking bolus insulin before eating. She does not know how much she is going to eat. So we're not sure whether we can give bolus insulin. We discussed that already, that we can use uh, faster acting insulin 15-20 minutes before acting, losing Humalog, Apidra, or Novorapid or Novolog, or we can use ultra rapid acting insulin like Fiasp or Lyumjev to be taken immediately before eating or immediately after eating, and take care of that problem with using insulin. Yeah, we can use immediately after eating ultra rapid and rapid acting insulin as well. And the next issue is that she doesn't even remember taking, she's type 2 diabetes, she has to take one dose a day, but she does not remember taking it herself, or she does not know how to take it, or has tremors and she cannot take it. But she has a family member who can give it, but the family member says sometime day duty, sometime night duty, and cannot be at the right time every single day. In that regard, there has been a trial with insulin degludec to be given either every 36 hours or 12 hours, 36 hours, 12 hours, 36 hours, 24 hours, and 12 hours, various changing frequencies. So basically, they're given one injection every day, either morning sometime or evening some other time. There is absolutely no difference in the hemoglobin A1C concentration compared to glargine U100. There is no difference in serum and self-monitored plasma glucose, self-monitored capillary glucose, and there is slightly less, if anything, episodes of hypoglycemia when varying duration of insulin is used. So the solution is that a patient can't even take one injection per day, and a family member has to give, but cannot give at the same time every day. One can use insulin degludec once a day, whenever you get a chance, take a dose, and that's almost all to it. So to summarize then, the solutions of current insulin problems in terms of newer insulin preparations is that if there is painful volume of injection, we can use higher concentration of insulin so that even one injection give larger volume, so a smaller volume and give one dose, and we can get away with it, or we can use inhaled insulin. There are too many injections, we can use concentrated insulin, or we can change the plan that does not take too many injections. That works for type 2 diabetes, not for type 1. We can use basal insulin that doesn't last long enough. We can use the one that lasts longer, like insulin degludec or glargine. There is substantial day-to-day variability in insulin action. We can use insulin degludec, which has less day-to-day variability. Possibly 2J is less than, yes, U300 glargine is less than U100 glargine. And can't or don't remember to take insulin before eating, we can use ultra-rapid acting insulin before eating or even after eating. And then we can use inhaled insulin after eating. Or if there is elderly patient that cannot even remember to take one dose per day, then we can give one injection of degludec at least once a day, so patient is somewhat controlled. Uh, thank you so very much for your patient listening. I'm delighted to answer any questions if there are.
Thank you, Dr. Shah, for that very informative talk. We'll see whether we have got questions. Right. Mm, I think, so the newer insulins, most of these insulins are not available in Sri Lanka, so that may be why that we don't have a lot of questions, because everything is new to us. We are yet to experience, so we do have ultra fast insulin, short acting ones, but not the long acting ones, not in common practice. So I was wondering, until we get any other questions, when you give somebody ultra long acting like insulin degludec, how do you decide on the dose? Like, is there a starting dose like in an elderly person? Like, what's the starting dose and how do we go about it?
So it's not very different from starting dose of glargine. I would, if it is elderly type 2 diabetes, we are starting 0.1 to 0.2 unit per kilogram body weight. So, 7 units, 10 units, something like that. Gradually bring down the glucose concentrations in a good range in the morning and then decide where to go.
Right. Thank you
Is
very
there
much.
any rationale for
Yeah.
combining twice a day
Combining
premix?
twice a day premixed with basal long acting insulin.
I don't know. I cannot think. I mean, one can combine. I suppose it'd be difficult to adjust the insulin doses. We have a senior fellow here, Dr. Chaco. I'll take her opinion also. Yeah, so we don't usually do that. Um, so question then that could be that taking I'm just thinking aloud. Pre-mixed insulin taken twice a day before breakfast and before evening meal, and basal insulin given. That can be of some practical benefit in case I'm not sure whether I'm going to eat each of the meals, and then I cannot give pre-mixed insulin if I'm not eating a meal. Then basal insulin prevent diabetic ketoacidosis, at least in somebody who's predisposed to develop that. This is very far-fetched. I've never seen pre-mixed insulin combined with long-acting insulin. Um, I don't know who is asking this question. Maybe there is some specifics that they want to tell me, and I can
Yeah,
clarify.
actually, I think maybe so in Sri Lanka, some people do use this, but I don't think it is done with proper, thinking as you were thinking. So it's it's mainly because people are in Sri Lanka, the people are not geared to take pre-meal insulins, like three insulin injections before meals is not practical in Sri Lanka. That's why we go for pre-mixed. But I think, yeah, so probably this is not the ideal practice, though we see it in Sri Lanka.
Yeah, the problem is the question is how to change the doses. That will be the issue. Wondering why inhaled insulin is too late to come into role. Are any advantages other than, yeah, it acts quicker, but the problem is that it goes away quicker also. So that is the advantage. I think the only advantage, it works quicker. There are reasonable data now that it works in type 1 diabetes. I was very reluctant to think because they have fixed doses of inhaled insulin, 3 units, 6 units, or something of 2 units, 4 units, 8 units. So it becomes a little tricky in type 1 diabetes. So they will be reasonable for type 2 diabetes, but not necessarily for uh, type 1. But there are studies that imply that maybe, they will be useful. We'll have more data come in. I think I have prescribed only once in my life. Dr.
Okay.
Chaco has never prescribed, my senior fellow here, she has never prescribed it. So I don't quite know. The next question is, can you please brief us on Ozempic? Well,
Right.
Ozempic,
Thank you. Yeah, that's again something that everybody wanted to know, but because of the time limit, I said we will go for one like insulins, but this is something that everybody wants to know. So it would be good if you could tell a little bit about it.
yeah. So in my experience also, nobody wants to see me for longer than half an hour at a stretch. Um, just kidding. But Ozempic is a GLP-1 receptor agonist. It works on GLP-1 receptors. Essentially, it causes a slight increase in insulin secretion and decrease in glucagon secretion when glucose is high. But it also slows down gastric emptying and it reduces appetite by working centrally. Now, then, if you look at the reviews, there are about, I don't know, 50 reviews published every year on this. They will say that it acts in blood vessels and so many things, and maybe it does. But these are the critical things, are those things. So what that does is that it reduces the appetite, it reduces the desire to eat food. People eat less food, they lose weight. When they lose weight, they need less insulin, or they stop taking insulin, or their blood sugars are controlled. In any case, if they don't eat as often, then they don't need as much of meal insulin if they're taking insulin. So that way it helps, it slows down gastric emptying, slow. So when I eat, I am full for longer period of time. So I don't pick up a cookie just when I see it like I do otherwise. So that is helpful in controlling blood glucose. Leads to weight loss, maybe 10%, 15% weight loss can be achieved. The problem in people with diabetes, that weight loss is less, about half of what is seen in people without diabetes. Uh, and uh, and it also causes nausea. So about 50% of people will have nausea when started on Ozempic. Uh, so my take is that Ozempic doses have to be increased on a monthly basis or less often than that. So what I tell people is to start at the lowest dose. If you have vomiting or diarrhea or bad constipation, don't take the next dose. Talk to me, I'll talk to them, and then we'll decide where to go. If you have nausea, then they keep taking it. If it is mild nausea, nausea goes away. I want to wait for at least 1 full month before we increase the dose. Because if we increase the dose with nausea is already there, it will cause vomiting at the next dose. So at any dose there is vomiting, they'll cut back the dose to the previous one. At any dose, if there is nausea, they will not increase the dose. As we increase the dose, the weight loss is more, but blood glucose control benefit is quite a bit light right in the beginning in the smaller doses. So sometimes if we just for blood glucose and weight loss is not the target, then we tend to not necessarily increase the dose. Other thing it does is, of course, it reduces weight. When we lose weight, we lose fat. When we lose fat, we can pick up the fatty acids from blood. So the fat goes down from blood, and that will improve sensitivity to insulin, and we'll need less insulin for that reason also. But it removes fat from places where it should not be. It removes fat from muscle, increasing muscle sensitivity. It removes fat from liver, reducing liver fat. It actually reduces liver inflammation. And if data has to be believed, it reduces fibrosis as well. So it is very helpful in fatty liver disease with early fibrosis. It reduces fat from pancreas. So it's supposed that the fat in pancreas destroys the insulin producing cells. So it reduces that and reduces the toxic effect of fat on pancreas as well. So it has multiple benefits. Who cares? When we use metformin in people who are at high risk of heart attack, about 15 to 20% reduction in heart attack. This is on top of 95% people taking cholesterol medicine. This is on top of about 80-85% people taking aspirin. This is on top of about 85 to 90% people on ACE inhibitors or ARB. So on every other measure, this will reduce the risk of heart attack by another 15 to 20%. It reduces the risk of heart failure and hospitalization. Actually, it decreases the risk of, it improves the quality of life in people who have heart failure with preserved ejection fraction. And if secondary analyses have to be believed, even in those with reduced ejection fraction. And it reduces the progression of kidney disease from early kidney disease to kidney failure in people. So mind you, all these studies are in people who are overweight or obese. Almost all of them are overweight or obese. So what happens in lean people like, good old Sri Lankans and Indians who don't have the BMI of 30, 35, but they have a BMI of 25, but they still have liver fat. Will it have similar effect? I would expect that, but we don't know. We don't have studies in that population that much. But based on the data on weight loss, etc., in that population, a 10% weight loss in a person of BMI of 35 gives similar metabolic benefit as 10% weight loss in BMI of 25. So it possibly helps there. The biggest problem, as I said, was nausea, vomiting, diarrhea, constipation. There can be obnoxiously bad constipation. We actually had a month back somebody who was vomiting feces, fecal material. He was just being given injections by somebody. Don't stop because of terrible constipation. So it can be really bad constipation. So that's about Ozempic. It's expensive medicine. Hopefully, the ingenuity of Indians and Sri Lankans will have biosimilars as they have for liraglutide, at least in India, I'm sure in Sri Lanka as well. Much less expensive versions should be coming out soon, and that'll be helpful.
Right. Thank you, Dr. Shah. There's another question. Does any of the new insulins provide weight loss or help with cardiovascular complications?
There is some data that suggests that even longer acting insulin, you 500, you 300, or glargine or degludec insulin has some less weight gain, but it is not a weight loss. Maybe the difference of half a kilo or a kilo or something. It's not any substantial difference. There is absolutely no data on our.
What about
Not in.
cardiovascular complications? Is there like
No, not that I know of any differences in cardiovascular outcomes in these people. They've never been studied to the best of my knowledge to any great degree. I mean, there may be some association studies, but I wouldn't go by that.
Okay, thank you. And there's another question. What would be the cutoff value of HbA1c to start insulin straight away or as an add-on therapy for metformin?
So I would not start insulin straight away based on hemoglobin A1C. I would start based on clinical evaluation of the patient. So patient, let's say, has a glucose of 300 milligram per deciliter hemoglobin A1C, and I'm telling you real numbers here. More than 300 milligram hemoglobin A1C of 12.5%. And you ask the patient and say, what is happening? Oh, I was just diagnosed to have diabetes. How are you doing? I'm doing well. I just have increased thirst for last 6 weeks. I'm having too much thirst. So what do you drink? Yeah, I drink what I normally drink. Okay, but what is that? Yes, I drink Coca-Cola. What do you do? Diet Coke or do you do regular Coke? Oh, I never like Diet Coke. I only drink regular Coke. So all they have to do is to stop regular Coke and blood glucose will go down to 150. So many of these patients with hemoglobin A1C of 300 or hemoglobin A1C of 12% and glucose of 300 milligrams is because they didn't even know that they have diabetes, that they were not even restricting basics of diet. So they can substantially be improved by merely changing diet. I would argue that even if we didn't give metformin, the hemoglobin A1C next time will be 7%. On the other hand, somebody has been having diabetes or pre-diabetes for several years, now on metformin, now hemoglobin A1C is 8% and fasting glucose is 160, 180 or something. Metformin is doing all it can do, diet is reasonable and not doing anything crazy. Well, we need to add something. Then the question is whether we would add insulin or we would add gliclazide or glipizide or glimepiride. We generally don't use glibenclamide. We tend to use glimepiride or glipizide here, and of course you have the luxury of using gliclazide as well. So the question is whether to use sulfonylurea or use long-acting insulin. And I don't know if there is any difference between the two in terms of outcomes. I think there are some differences compared to not taking sulfonylurea or insulin, but taking sulfonylurea or insulin, there would not be substantial differences in outcomes. Personally, I would use gliclazide rather than use starting longer acting insulin at that time. The problem with gliclazide or glipizide or glimepiride is that we use as if it is simple pill, give a dose, and then we start at the higher dose. And that can be disastrous. That can kill somebody. So as long as we are careful with sulfonylurea, starting at a very small dose and increasing only once a month or once in 3 months, we should be able to achieve good glucose control with the least possible dose and not increase the dose of glucose concentration is high because of dietary indiscretion. Then sulfonylurea is a very reasonable thing. On the other hand, if sulfonylurea is not to be used, adding long-acting insulin, that situation would be very, very useful. So I don't personally have any cutoff of hemoglobin A1C or even plasma glucose or starting insulin. On the other hand, if glucose is high and there is ketones or, then we start insulin there too, if it is because of drinking 2 liters of soda pop every day, Coca-Cola, or, people do that in US. I'm sure that's happening in India and Sri Lanka as well, that, people just keep drinking. That's all they drink is sugar-containing drinks. I had a good discussion with one of my patients yesterday that water does not suit him. He's allergic to water, but the sugar drink is okay for him, it seems. So, it's difficult to argue because that's what they've done all through their life. And now you are changing their life.
Right. Yeah, I think there's another one. Can't we prefer SGLT2 inhibitors to sulfonylureas?
Yeah, that is very much so. So SGLT2 inhibitors are possibly better than sulfonylureas, and certainly there is some data with sulfonylureas reducing cardiovascular events, etc. But this is the time before statins were available. This is the time before ACE inhibitors were given to everybody with diabetes, with hypertension, or microalbuminuria. So that is a different time than what it is now. But sulfonylurea there, it reduced. Gliclazide was a trial, right? And what is it called? Forgetting the name of the trial, but gliclazide use reduced mortality by 50%. So it does, if you control with gliclazide compared to not control, that of course would reduce the mortality. So that's no question that it reduces. But once again, there was different times. This is different time now. Using a statin, using this, that, everything will reduce mortality along with gliclazide. That gliclazide study was with statin addition, with making sure everything else is done all right and can reduce mortality by 50%. But yes, SGLT2 inhibitor certainly reduced mortality by another 15% on top of blood glucose control. Another 15% reduction in kidney failure on top of glucose control. Another 30 to 35% reduction in heart failure on top of heart failure medications in general. So I think there is reasonable data to argue that SGLT2 inhibitors are reasonably safe or possibly better than sulfonylureas. They are not as expensive as in Sri Lanka and India as they are in US. They are very expensive. So sometimes expense becomes a limiting factor for us.
Thank you. We have a lot of trainees also joining in. So like it would be good if you could quickly touch on Monjaro as well. Just
So Mounjaro is another GLP-1 receptor agonist, which also has slight action on GIP receptor. So what is incretin? Let me briefly talk about that. When we give glucose, let's say 100-gram glucose given intravenous, but same 100-gram glucose given by mouth, when we give it by mouth, insulin concentrations are higher than when the same amount of glucose is given intravenous. So at the same glucose levels, we make more insulin to bring down glucose faster than given intravenous. So that effect of higher insulin secretion by taking calories through mouth is called incretin effect. This is mediated by essentially two hormones, GLP-1 and GIP. So all the GLP-1 agonists so far were pure GLP-1 agonists. Now we have this Mounjaro, which is tirzepatide, which is GIP agonist as well as GLP-1 agonist. Now, some people tell me, and data would imply that GIP agonism is not that strong and it is much stronger GLP-1 agonist than other GLP-1 agonists, but that's besides the point. So Mounjaro is associated with more weight loss compared to Ozempic. Mounjaro is associated with better glucose control than Ozempic in head-to-head trial. But that head-to-head trial was up to 1 milligram of Ozempic, not 2 milligram of Ozempic. And Ozempic is now approved for 2 milligrams, so that's another problem. And nevertheless, it seems more weight loss with tirzepatide, with Mounjaro, compared to Ozempic. But yet, other than subgroup analysis or meta-analysis, etc., we don't have hard and fast data on cardiovascular outcome, renal outcome, heart failure with preserved ejection fraction, or heart failure with reduced ejection fraction. We don't have data on Mounjaro yet. So since we don't have the data, if the purpose is weight loss, Mounjaro is better than Ozempic without question. If purpose is only blood glucose control, Mounjaro is better than Ozempic without question. But the purpose is preventing heart attack, preventing kidney failure, preventing heart failure, etc., and preserve ejection fraction at least, then I would prefer Ozempic over Mounjaro today. You come back in a year, it may be different data once Mounjaro has something. That may be slightly different. Increasing doses similarly, we don't increase dose rapidly. Same problem can happen with Mounjaro as with Ozempic.
We have a final question and a comment. Dr. Surangamanigam has thanked you for the presentation, and he's asking, is there a role for adding or continuing a sulfonylurea alongside insulin therapy in a chronic type 2 diabetic patient with intrinsic insulin deficiency?
Yeah, so once I start insulin, not always, but when I'm adding 6 units, 8 units, 10 units of glargine to a person with type 2 diabetes, the sulfonylurea may continue. But usually I would stop sulfonylurea, but I'll be forced to stop sulfonylurea if there is any episode of hypoglycemia. So if there's any episode of hypoglycemia, what is causing hypoglycemia? Was it sulfonylurea causing hypoglycemia? Was it glargine? Which dose has to be reduced, changed, etc.? So there is a confusion of which one of the two causing hypoglycemia. So I would stop sulfonylurea when starting insulin, but definitely stop if there is any episode of hypoglycemia at all. And Dr. Manilgama, good to hear from you.
Okay. Right. Thank you very much. We had a very good discussion. So I think in the interest of time now, we have been here for 55 minutes. So we will call it a day. Thank you very much, Dr. Shah, for your time and for sharing your expertise with us and enlightening our trainees and the physicians. And then I would like to thank all the audience as well for your for attending this webinar and your active engagement with the discussions. Thank you very much.
But really, thank you for this opportunity. Have a good night. Bye-bye.
Good night.
Thank you.
Bye-bye.
Right.
Good night.